Okay, so hello everybody, and thank you for joining us for tonight's digital Infoday session on myeloma bone disease. My name is Katie and I'm one of the myeloma information specialists here at Myeloma UK. So before we hear from our speakers this evening, I'm going to tell you a little bit about Myeloma UK. Myeloma UK exists to support all those affected by myeloma and its related conditions, including smouldering myeloma, MGUS and AL amyloidosis. We are patient-focused and we aim to empower, support and inform patients in everything that we do. As an organisation, we rely on the generosity and kindness of supporters who fundraise and donate. Myeloma UK receives no core government funding, so your support is vital, and we are truly thankful for all contributions, as it allows us to continue to work to support patients, their families and their friends. So tonight's Infoday session is being recorded and it will be available to watch on our Facebook page and our website soon after. We will be popping website links, publications and any other useful information into the chat box throughout the event. If you think of any questions that you would like to ask, then please use the Q&A box on your screen and we will try to answer as many of them as possible. So in this session, you will hear about how myeloma bone disease is monitored and the complications that might arise. We'll also be discussing treatment and offer helpful and practical tips for living with myeloma bone disease, including how to exercise safely, which is something that we often get asked about through the myeloma info line and through our Ask the Nurse email service. So today I'm joined by two speakers who will be giving us two short presentations. We have Dr. Chara Kyriakou, who is a consultant haematologist at University College London Hospital's NHS Foundation Trust, and Sarah Jalali, who is clinical lead and a specialist physiotherapist in haematology and oncology at Bart's Cancer Centre and Bart's Health Centre NHS Trust. So welcome to both of you and thank you both of you for joining us this evening. Firstly, I'm going to hand over to Dr. Chara Kyriakou, who is going to give us an overview of myeloma bone disease.
Thank you, Katie, and sorry for the technical problem. Thank you for giving me the opportunity to discuss with you about myeloma bone disease, and thank you all for joining this webinar. I will highlight what we will discuss about shortly, and the next slide, please, Katie. And what I would try in the next 15 minutes, if I could do that, is to discuss with you how myeloma can affect your bones and how this myeloma skeletal bone disease cause complications to the short or longer term. And in addition, how we manage the myeloma bone disease. The next slide, please. So we know that the body is made in such a way that we have a cycle of maintenance of functionality of major organs. And in the case of the myeloma bone, as you can see in this nice picture there, we have to maintain the balance for good bone health. You require the blood vessels to supply nutritional factors for the bones and minerals, and also you have the cells involved in the homeostasis or the balance of maintaining bone. The two big players from the cell point of view is the osteoclast that are causing breakdown of the bone, and the osteoblasts that are helping to rebuild and to help for bone formation. What happens in the myeloma patients is that these big players have some neighbors, and their neighbors is when, for some reason, the body starts having this uncontrolled proliferation of the myeloma or plasma cells. These plasma cells are secreting proteins that are triggering the osteoclast to multiply, and the osteoclasts are producing substances and proteins that are causing bone erosion, in addition to the substances that the myeloma cells are secreting, causing further bone breakdown. As a result from this process, what we see is that the bone formation pathway in this cycle that you can see in the scheme is broken, and the bone formation is suppressed, and we have uncontrolled osteoclastic activity, and as a result, we have more and more bone erosion. And the next slide, please, Katie. And with the time that can be faster or less fast in different cases, what happens is that this continuous destruction of the bone can lead to bone holes. And depending on where these bone holes are and which bone they're affecting, they become bigger. And the bigger they become and the side they're affecting, they can cross the line, and then we can have breaking and fracture. And many times we see people complaining about discomfort, about pain. And then what will take them to the hospital and emergency department is when things get really severe. And although they've been managing pain with pain control or other medication, this is getting worse and worse. As a result of continuous bone destruction, we have quite uncontrolled release of calcium and in the blood. And we have a condition that is called hypercalcemia. And this hypercalcemia can cause afterwards kidney problems or confusion or gastrointestinal issues. And again, these are different symptoms that will make the person to seek advice in the hospital. It's not unusual in myeloma to see people with bone holes or bone lesions. The question is, what is the severity of these bone lesions? And what is the consequences for people developing? More than 70% of our patient population present with some form of bone disease. And the majority of the people at some point in the course of myeloma disease, they will experience some form of bone damage. Usually the bones that are affected with from this process are the bones that are having high blood flow, and it's not unusual to see people having multiple fractures across the spine or the sternum or the head of the humerus or the femur, or sometimes pelvic problems as well. And unfortunately, in the past, we didn't have so many clever imaging techniques to identify early on this development of the bone lesions. And with the plain x-rays of the bones to see the damage, you need to have more than 40 or 50% destruction of the bone to show in the x-rays. Whereas in nowadays, we have more imaging, whether it's CT or PET-CT or MRI, or depending on which imaging technique your consultant will decide that will be the best approach to identify the lesions. And we can then be able to identify a bit earlier and hopefully be able to prevent more severe damage for the future as well. The next slide, please, Katie. You can move to the next slide. Thank you, Kate. In the case of the spinal disease, what happens is that you have diffuse infiltration with the plasma cells and the activity. And many times, because our spine is holding our body, it's easy because with the ongoing process, the spinal vertebral body become more fragile, and you have compression or compression fractures. And what you can see is that you can see height loss, you can see pain because either the compression fracture can compress the exit route of the nerves, or you have radiating pain. And sometimes the collapse of the vertebral body can happen in such a way that part of this bony element can compress the spinal cord. And this can cause a very severe complication that is called spinal cord compression, that is causing problems with bladder or the bowels or mobility problems. And it's an acute emergency for us to sort out, and to sort out very urgently. And also when we do our myeloma spinal clinic at Stanmore, although we are very stressed to sort out the acute and intermediate problems, we are looking also to make sure that we prevent longer term problems, because with the pain, you feel more comfortable bending to release a bit the pain. And gradually what happens is that the spine is bending and bending, and this can cause longer term deformities if we don't act early on in the management of the myeloma spine as well. The next line, please, Katie. The treatment for the myeloma bone diseases general starts actually with the first and excruciating problem is pain. So pain control is very important. And then we start with the steroids, that is the cornerstone of any combination therapies your myeloma experts are treating you with. You start with your systemic therapy, and then together with that, or in parallel with that, we give you what we call bisphosphonates, that are drugs that are blocking this abnormal cycle with the osteoclastic activity and proliferation. And what these bisphosphonates are doing when they're incorporated with the osteoclast is to block their activity and their proliferation. So by doing that, and in parallel with the good results that your myeloma treatment is giving by clearing the myeloma cells, together they are blocking the osteoclastic process. And this gives the chance for the osteoblastic activity to be re-triggered and to finally compensate and start the bone formation process as well. The bisphosphonates that are given for myeloma bone disease can vary between different people, and this depends on different factors like kidney function, cardiac function, or any other individuality each of you might have that we need to adjust. The frequency of the bisphosphonates also varies between different people. Usually we start with monthly infusions, and we do a pause for them, people who go for their transplant for 3 to 4 months to reduce bisphosphonate-related toxicity. And then we continue for the first 2 years. The second year, we go once every 3 months. And then taking into account multiple other factors, we decide about the frequency and how we continue, because we are happy that we witness long survival in our myeloma patients. So we have the luxury of modifying the way that we administer the bisphosphonates to maintain good bone health, but by reducing also at the same time the longer-term toxicity that these drugs can cause as well. If you go to the next slide, please, Katie. I wanted to stay a bit in the management of the spinal compression.
Okay, everybody, just bear with us for a few minutes while we wait for Chara to come back on.
Can you hear me?
Yes, we can hear you now.
Apologies for the connection. So when we are dealing with the vertebral spinal fractures, we can have one level or multiple levels. And depending on the nature of the fracture, we decide how we specifically manage the spine. Apart from the pain relief, apart from the myeloma treatment, in some cases we have myeloma people who have soft tissue myeloma mass together with the broken vertebral body, and radiotherapy could also help. But when we try to clear the mass and we have quite fragile eroded vertebral bodies, that could possibly cause subsequent further collapses in this spine as well. And what we're doing, we try to support bracing, and the bracing can be either from CTLSO that covers from the chin down to the pelvis, or TLSO, and this depends on which level the vertebral body fracture happened, and also the nature, and also we take into account whether people can have sternal fracture that can drag the spine and they can cause some more subsequent fractures as well. In the past, I think a decade ago, when we started the clinic at Stanmore, we used to have more interventional procedures, and One of them is showing in this slide was with the cement augmentation, which what the surgeons are doing, they try to inflate a balloon around the vertebral body so they can have control of the injected cement and they don't have leak of the cement everywhere in the body. And by doing that, what they are expecting is to partially restore the vertebral body height, but in addition, by doing this can give pain relief. What we have witnessed the last, especially the last 3 to 4 years, we have reduced even this interventional minimally invasive technique. And the reason we managed to achieve that is because we are better in how we brace individuals by measuring and adjusting the brace to their needs. And in addition, we have put some guidelines that to need to go for this interventional technique, that means that the person has persistent pain in their spine, not responding to the treatment and the pain relief, and the degree of the pain is quite high, and then we can interfere and we can offer the cement augmentation. In the past also, a lot of units used to do a lot of spinal metal work to deliver more spinal stability, but we have not done that for years, and this is because any problems as well. The next slide, please, Katie. Living with bone disease is many times quite frustrating, and I know that when I first have to give diagnosis to a person with bone disease, and I many times have to deal with people who present and they need to be bent bound because of the severity of the bone disease they are presenting with, or because they need to have pinning of their femur or total hip replacement operation, or because they need to wear this brace that is like a very stiff armor there that is quite uncomfortable. I know that when I talk to you and I say, you know, that at some point next year you will run after your grandchildren, you think I'm making really bad jokes with you, but it takes time to control, especially the cases that present with quite advanced bone disease. In the past, it used to be considered as inferior factor for outcomes, but nowadays, with improvement in the drugs we give for the treatment of myeloma bone disease, and also more specializing the supportive mechanical care, we have witnessed amazing responses. We know that when we give you all these treatments, some of the holes will not be completely healed. We know that we cannot fully reverse the damage that was done, but for as long as we can fix the damage that will get you back to functionality without compromising your quality of life, that will not be an impact or an obstructive factor in the future to be able to live as normal as possible. Many times I see my younger or older group of people that become friends that feel uncomfortable using the stick or using the crutches or the frame. And what I always say to you in the first instance, and especially the first 3 to 4 months, and until we manage to stabilize, until all these treatments start helping your body to develop better bone formation around the wounded sites and start inducing internal stability so you can get rid of the brace, you cannot get rid of the crutches or the wheelchair or whatever, it takes a bit of time. And the time can vary for different people depending on the severity. We continue with the treatment that continues helping the bone formation, and is something that we need to stress here is the bone bisphosphonate therapy. Since the day of diagnosis, I'm sure that all of you have leaflets about having dental review and about making sure that we are all working together to maintain good mouth hygiene, and in case of any dental or ear infections or any mouth ulcers are addressed straight away. The bisphosphonate stays in your skeleton, But what we can do in case these problems rise, we can discuss with the oral maxillofacial team, the dental team, to help us. So with good antibiotic cover mouthwashes, we can help to prevent a not very pleasant complication that is becoming more rare in nowadays, and it's called osteonecrosis of the jaw. With your treatment, and because the bone disease can compromise your mobility to start with, and the physiotherapy and the mobilization is taking a bit of time, in addition to the drugs that we are giving you, like the steroids or some of the other medication that you have that can cause myopathy or muscle wasting, that can make the recovery and the rehabilitation a bit slower. But for as long as we secure with the spinal surgeons or the orthopedic specialists, and we have imaging confirmation that we can mobilize you, then what Sarah will go through as well shortly is that the physiotherapy within your capacity is quite crucial together with the rest of your overall treatment, so we can mobilize further and further, so we don't run into troubles in the longer term with further problems, because restricted mobility means more infections and more other longer term complications as well. And the next slide, Katie, please. I know that it's a very short time to go through the whole field of myeloma bone disease, but what I tried to talk to you about was how these holes are developed, why the bigger these holes are becoming, the bigger there is for fracture, and why your doctors try to make sure that they stabilize these sites, either by some intervention with pinning or with some orthotics, or whatever is required based on which area of your body, and that the treatment is combined treatment with the systemic therapy, with the pain relief, with the bisphosphonates, with radiotherapy, and with the mechanical spinal support, together with physiotherapy that can get you back to functional lifestyle and get you back to your old routine. Possibly it's not going to be 100%, but as high as possible. And with that, I would like to thank you, because I think it's better to allow you to ask questions rather than me talking more about myeloma bone disease. Thank you very much.
Thank you very much, Dr. Chara Kyriakou. That was very useful and informative, and I'm sure people listening will have found it very positive to hear that there are lots of ways to manage myeloma bone disease, and that there is hope that they can get a good quality of life back again. So thank you for that. Next, we're going to hear from Sarah Jalali, who's going to tell us a little bit more about how to stay active when living with myeloma bone disease.
Thank you for the intro there, Katie. If we can move to the first slide. So over the next 10 minutes, I'm going to discuss with you why being active is important for people with myeloma, what the recommendations are over physical activity, and how that might look for those activity ideas. Next slide, please. And I guess there's sort of 3 take-home messages that I'm going to try and drill in. And I think it's important to remember that people with myeloma can be and should be active, but there may be individual considerations and adaptations to think about. Always, if in doubt, please speak to a health professional, be it your nurse, physio or exercise specialist who understands myeloma and who can give you further advice. Next slide, please. So you'll notice that I refer to physical activity as opposed to exercise, and that's because people often associate exercise with something that's highly structured and they don't like it, for example, going to the gym. But actually what we know is being active is important, and being active refers to moving in various shapes and forms. So that could be dancing in the kitchen, it could be playing with your grandchildren, it could be walking to the shops or work. So that's why I refer to physical activity. Next slide, please. And actually what we do know is in today's society that not moving and being physically inactive can really impact on people's abilities to carry out normal everyday tasks. Next slide, please. And specifically from a myeloma perspective, we know that research is now showing that being physically active is not only safe for people with myeloma, but has multiple benefits. So by increasing muscle strength and overall cardiorespiratory fitness, that can improve our ability to carry out those everyday tasks. And it's also known to improve with some of the other side effects, such as fatigue, sleep, low mood, and peripheral neuropathies. Next slide, please. So looking at how active we should be. So times have moved on from the days where we used to tell people to rest in bed or rest up because you're having treatment. As I said before, we know that being active is safe and is beneficial, and that's even when you're going through active treatment of your myeloma. Next slide, please. So how active should one be? Firstly, it's important to remember to build up. So if you're not doing too much at the moment, we don't want you to go to the other spectrum and try and be doing 2.5 hours a week or twice weekly resistance. So it's about building up. Think of it more on a spectrum, but actually doing something is always better than doing nothing at all. Next slide, please. So what the overall exercise recommendations are moderate aerobic exercise, so at least 150 to 300 minutes a week, or vigorous aerobic exercise, at least 75 to 150 minutes per week, or you can do a combination of both, and then adding in some resistance to that. When we're looking at moderate, I think it's important to think when you're exercising, you should be able to hum a tune, but you shouldn't be able to sing a song. If you can sing a song, you can probably push yourself a little bit more. Next slide, please. And also what we do know is that for certain symptoms that people experience, research is now showing that by tweaking your exercise a little bit, that can really impact with some of those symptoms. So for example, if you are experiencing fatigue, aerobic exercise at 3 times a week for between 30 and 60 minutes can help. And it's important to remember it doesn't have to be 30 minutes solid. It can be 10 minutes in 3 times a day. So it's up to you how you break that up. Next slide, please. Of course, there are some considerations to take with myeloma. So we'll just go through some of those now. So neutropenia. So if you have got low neutrophils, that can increase our risk of infection, and therefore it's important to just think about avoiding those activities that may increase our risk of developing an infection. So for example, going to a swimming pool or participating in group classes. Next slide, please. Anemia, so having low hemoglobin levels, they can often make us feel quite fatigued or quite short of breath. And for that reason, again, if you're suffering from low red blood, it's not worth overexerting. It's probably going to make you feel worse than better. And so that's why we tell you to sort of calm it down if you've got that. Next slide, please. And again, low platelets. So often again, if you've got low platelets, that can increase your risk of bruising and bleeding, particularly from injury. So again, it's not that you can't exercise, it's about thinking about what you can do. So avoiding things that are high impact or very heavy weights, or things that might increase your risk of falling are the considerations to take there. Next slide, please. So overall, as I've just mentioned, you may need to think about avoiding high impact or contact sports. So not only if you're neutropenic, but if you've got that bone disease. And again, because your bones are potentially not as strong as what they were without any bone disease there, we're trying to minimize the risk of causing any fracture. Some adaptations or modifications to some exercises depending on the location of bone disease. So often what we'll recommend for some exercises, depending where your disease is, you might want to avoid too much rotation. So thinking about perhaps golf swing or some dance moves. We also recommend avoiding going to end range of movements. So if you were in the gym, for example, if you were doing a bicep curl, you may not do the full range through that movement. And again, this is where I think it's really important to speak to a health professional, particularly if you start to experience new or increasing pain during exercise or activity, because that's not what we're aiming to do. Next slide, please. So some options, so you could think about things like swimming or aqua aerobics. Again, just bearing in mind that you're not neutropenic. Walking is always a good option. Things like Tai Chi and yoga, again, thinking about sometimes some of those positions may need adapting. I put stationary cycling on there, more just because of the risk of falling off your bike if you're doing a lot of road cycling. Gym-based programs, if that's your preference. Again, there may be some adaptations to some of the movements, or other options like gardening. Again, I would just always say, speak to someone, tell them what you want to be able to do, because if you have that conversation, normally we can find something rather than it being a outright, no, avoid that activity altogether. Next slide, please. So that was a whistle-stop tour of physical activity. More than happy to answer more questions around that in the Q&A session that follows. Yeah. Again, I'm just going to reiterate those take-home messages. So we know that being active is beneficial for patients with myeloma, and that's at any point, whether you're going through active treatment or you're more on surveillance. But please be aware of your bone health and the side effects or complications, seeking advice when needed. And there's always lots of different options that can be found for you to do. It's just a matter of having those conversations and getting things tailored towards your needs.
Great, thank you so much for that, Sarah. That was really interesting, and hopefully it's helped people listening feel a bit more confident knowing what kind of exercises are safe for them to be doing and what they should be avoiding. So thank you for that. We have now reached the question and answer section of today's event. So thank you to everybody who has submitted questions in advance. If you would like to submit any more, then you can use the question and answer box still. So the first question that we have for both of you is a question from Susan, and she's asked, if you have not had bone issues before diagnosis, how will I recognise myeloma-related bone damage as opposed to age-related bone problems?
Shall I answer the question, Sarah?
Yeah, I'll chip in if there's anything extra to add.
Obviously, there is difference when people first present with myeloma and different when we have follow-up. Usually when we monitor people closely in our clinics, we examine or we ask questions or people report symptoms, and based on the nature of the symptom, we can decide whether we need to do, as I mentioned earlier in my talk, the imaging, whether it's MRI or PET-CT, which will give us the opportunity to identify early on if it's an ongoing process that is myeloma related. If we exclude that, yes, people can have arthritis, can have tendinitis, can have any other causes that can be related with their pain, but we always monitor and taking into account the blood results, how our examination is, and what is the symptoms a person reports, we can then be guided to do the right test at the earlier stage so we can diagnose early and we can support the person early as well.
Great. Thank you for that. Okay, so now we have a live question that's coming from Marion, who's asked, what are the activity recommendations if you have other conditions or a disability?
I think that can vary depending on what the condition or the disability is. It's quite hard to be overly specific. Most places have resources, so depending on what that condition is, and then it's a matter of trying to sort of fit both in, if that makes sense. So I'm trying to think of an example now. If you had cardiac problems, for example, I'm sure if you went on the British Heart Foundation website, that might give you some recommendations relating to your heart health, and then you may just need to incorporate some relating to myeloma there. But I think that's why it's always important to try and speak to someone if you can, because then you get that specific information that's tailored to you.
Great, thank you, Sarah. And yeah, I'd agree. It's always a good idea to speak to your specialists and your consultants if you have any specific questions that you're not sure of. So next we have a good question from James, who's asking, at what stage do you get bone disease, and is it reversible when you're taking treatments?
You can get bone disease either from the beginning, or you can still get disease during subsequent relapses. We are happy to witness a lot of new drug developments and to see our people living with myeloma for years and years, and which is quite nice. But we know that at some point we haven't reached the time that we have a curable approach at the moment, and we know that at one of their relapses, they might relapse with bone disease as well. And again, back to what I mentioned earlier, because the advantage when is during the follow-up is because we monitor, we can minimize the longer-term damage or consequences. About reverse of the damage, we can partially correct the damage, but we cannot fully heal the lesions or the bone damage that has happened. But by acting early on and protecting and allowing bone formation around the areas that were critical and they were causing instability, pain, or other issues, that means that with the time, we can go back to functionality to be able for people to continue with the activity that Sarah mentioned earlier as well.
Great, thank you for that. So now we've got a question that quite a few people have asked. Are there any particular parts of the body I should be exercising and strengthening more than others?
I wouldn't be particularly focused on parts of the body per se. You'd be looking at trying to incorporate a bit of strength into your exercise and a bit of aerobic plus or minus balance. So you're looking at your whole body. It's just the way that you may exercise or move. I don't know if that answers the question completely.
Yeah, I think that's useful. Thank you, Sarah. Okay, so we can move on to our next question, which is a question from Dorothy, who has asked, can patients receive hip or knee replacement surgery while on treatment?
The answer is yes, is the question, of course, and that you need to discuss with the myeloma and the orthopedic expert is the timing, because we give you treatments. The treatments can cause either low platelet count or low blood results, meaning that you can be at risk for bleeding or for infections. We give you thromboprophylaxis, blood thinners, so we need to make sure that we plan the procedure carefully to reduce bleeding complications, and even more importantly, actually, to reduce infection complication. And it's not unusual to try to modify the way we give our treatment for as long as we are allowed to move on in emergency situation to do the procedure, but is quite important to have it under antibiotic cover and taking all the precautions about bleeding and thrombosis. And it requires a very careful planning between the multidisciplinary teams involved.
Great, Thank you for that, Chara. Okay, so our next question, again, I'm sure lots of patients will be keen to get some advice on this. Can taking calcium and vitamin supplements help with myeloma bone disease?
Yes, because these are the ingredients that they are helping, as I showed earlier, to rebuild as much as possible our bones. The problem with the calcium tablets at diagnosis and when people present or when we have the acute fracture or acute bone disease, the calcium can be high at this point. So what we want is to normalize that. And when we get a good response, then calcium and vitamin D and zoledronic acid together with the magnesium sometimes are quite critical to maintain good bone health and to sustain that.
Great, thank you for that information. So we've got another live question, which quite a few people have been asking. Is golf a safe sport to play?
I think it depends where your bony disease is. You may need to take some changes if you're thinking about that golf swing and the level of rotation. So if you've got disease in your spine, that's where you may need to make the changes. But otherwise, in terms of 9 holes, 18 holes, that would be absolutely fine. And if you've got any disease in your long bones, playing golf would be fine. It's just about managing anything in your spine.
Great, thank you. So now we've got a question from Anne, who has said, I have had myeloma for 18 years. Recently, I've had osteonecrosis of the jaw as I was on bisphosphonates. How common is osteonecrosis of the jaw, and is there anything patients can do to help manage it?
Actually, it was more frequent complication to see early days when we started using this highly potent bisphosphonate like the zoledronic acid. And we don't see it as often now. The incidence is getting lower and lower. But the management of this depends on the staging of the osteonecrosis of the jaw. We collaborate with specialists from the maxillofacial dental departments that they can assess the damage, because if it's early stage, they can manage with mouthwashes and antibiotics. But depending on the severity of the osteonecrosis of the jaw, the MaxFax people can guide us and they can support to avoid further problems for the person who has developed. As I said, I don't know how many years Anne had the bisphosphonate, and obviously on and off, and this is a difference in nowadays that we see. In the past, when I was doing my PhD back in 2004, we didn't have too many drugs and we were giving non-stop bisphosphonates, whereas now we achieve remission periods for 3 or 4 years. So this is when we need to ourselves learn how to use these bisphosphonates differently as well. But there is specialized center for Anne to have the review, and I'm sure that your specialist will guide her how to manage that as well.
Great, thank you for that. So now we've got another exercise related question. I find it hard to tell if I've overdone it when exercising or if I'm feeling fatigued from treatment. How can I safely know when I've done enough exercise? Is there a specific amount of time? So I think you briefly touched on that in your presentation, Sarah, but is there anything else to add?
So I think fatigue is an interesting one. When you are experiencing fatigue, as we know, being active can help manage that symptom, but it's a fine balance. If you over-exercise, it's likely that might just tip you into higher fatigue levels. My advice is normally, if you think about the level that you're exercising, you may have heard of the term RP, which is rate of perceived exertion. So that refers to how you are feeling in terms of the level of exertion at any one point. So it's very much how you're feeling, and that can change day to day. So if you thought about a scale of 0 to 10, you wouldn't want to be going above a 7 out of 10 on that scale. So anything below 7 out of 10, you should be okay exercising at. The other thing to then consider is the next day, how are you feeling? You may want to have a bit of a diary whilst you work out roughly where you're at, because what you'd be looking for is, can I carry out doing the things that I would normally do? Or if I'm feeling too tired, I may need to take that back a notch. It can take some time just to find the right balance. But there isn't sort of a specific right or wrong in terms of the prescription of exercise.
Great, thank you for that. And I think keeping a diary can be really helpful. We do have a patient diary available at Myeloma UK as well, which might be useful to help you keep track of that as well. So the next question is from Jeff, who's asked a question about the treatment that he's been having. So he said, I have just started infusions for bone repair following a stem cell transplant. I believe this to be zoledronic acid. How effective is this treatment, and how much quicker will my bones regenerate compared to not having the treatment?
Usually we start, I think that after recovering from the transplant, so we can avoid trouble with osteonecrosis, because close to the transplant, we avoid giving it. So usually after 3 months, we can recommence treatment with a zoledronic acid or any bisphosphonate. And the answer to the question whether it's benefiting is yes, because this is part of bone remodeling, is part of your treatment. In addition, Myeloma UK trial back in 2010, I think, has shown that not only is helping the bone health, but in addition is having further additional anti-myeloma effect together with your systemic therapy as well.
Okay, great. Thank you. So now we've got another question from Richard, who's asked, can any bone treatment result in bone health improvement while myeloma is active or in remission? Or is stabilizing what is there the best you can hope for?
So when the myeloma is active, the treatment with bisphosphonates together with the myeloma treatment are clearing the myeloma cells, and they're giving chance for the bone formation. So by giving the bisphosphonates at this point, we try to fasten a bit the remodeling of the bones. And when the myeloma achieves good response, by continuing supporting the body, because don't forget that with our treatments, we give drugs that they can cause osteoporosis, like the steroids, or some people can have other factors that can be associated with osteoporosis. So continuing with bone supportive therapy is supporting further the overall good bone health and reducing actually the further subsequent future skeletal events.
I think when you're thinking about just overall bone health as well, actually staying active contributes to that, because we know if you've got a bone that's not affected by myeloma, the more you use the bone, the stronger they stay. So I think staying active does certainly help with overall bone health.
Great. Thank you. And now we've got a question from Anita, who's asked, is there any connection between myeloma and osteoarthritis?
No, I think those are two different conditions, and we have means to differentiate the two. As I said, usually when people are complaining and it's a new onset of osteoarthritis, because the person has the history of myeloma, we don't leave it to chance. We try to make sure that we prove that by evidence, and the evidence is by doing the imaging to confirm what is the nature of the damage, and then we can, if we exclude myeloma, then we move on to support the person with the orthopedics for the arthritis.
Great. Thank you. So we've had a few people commenting that they're in remission, but they're still on Zometa, and they were asking, should this be stopped when they're in remission, or should they be still taking bisphosphonates?
That's the 1 million question. And that's a wonderful question for us, the myeloma experts, because we're debating and we have guidelines and guidelines because, as I mentioned earlier in the past, we kept giving the bisphosphonates because the survival was not so prolonged. Whereas now that we have prolonged survival, when we achieve, if we have published the guidelines as to how we continue, but still it's not enough because we need to individualize our approach with the bisphosphonates and the duration or the frequency, because you might have a gentleman who is 50 and he's in remission for 3 years, and you have a lady that is 70 and she has osteoporosis and she has diabetes, or there is some other comorbidity. So about the duration after the 2 years, because the majority of the centers continue up to 2 years with the bisphosphonates, afterwards we need to rationalize based on the individual. And then when we have relapse, we recommence bisphosphonate the same way we gave it in the first instance.
Great. Okay, hopefully that's cleared things up for those who are asking. So we've now had a question from Jane, who says, I am one of the small percentage of patients who had no evidence of bone disease at diagnosis, but most of us will develop bone disease during our myeloma journey. Why is this when we are being closely monitored? For example, a relapse can be picked up much quicker than our original diagnosis.
I think that possibly you could continue being one of the small percentage of the people that you might not develop bone disease in subsequent relapses. There's an ongoing research about that, why some people are more prone compared to others, and we need to analyze multiple factors related either to the comorbidities, to the disease, and to a lot of other factors to see whether we can pin down which group is less likely or more likely to develop, so we can prevent that. And about preventing, I think that you, in case people are symptomatic, because you have diagnosis, that means that we can prevent severe damage by reporting your symptoms. If you have any symptoms, you might not, as I repeat myself, you might not get bone disease at any time point. That would be wonderful. But if you are symptomatic in any way, it's always good to exclude rather than guesstimating.
Great. Thank you for that. So now we have a question about dental checkups. So why do I need a dental checkup before taking bisphosphonates?
I think it's very important to make sure that what is the dental status, and if there is any intervention that is required to be done before initiating the bisphosphonates. As I said, that we continue people on bisphosphonates for years, and bisphosphonates are staying in our skeleton. And there are other factors also that can predispose for this complication that the previous person mentioned about osteonecrosis of the jaw. If we know how to prevent and to support tooth extraction, tooth abscess, mouth ulcer around the bisphosphonate infusion, and by supporting with antibiotics and having regular checkups, what I always say to my people when I see them in the clinic, I'm becoming very boring with that. I said, in case you need any dental intervention, you need to mention to your dentist. Myeloma UK has produced really nice leaflets about that, and you can provide that to your dentist. And the dental community is fully aware of the risk. And then they will pick up the phone to discuss with your myeloma expert. They will know what drugs you take and how we can minimize risk either with bleeding in the dental table, or with infection, or with this rare osteonecrosis of the jaw complication.
Great, thank you. Okay, so now it's time for our final question of the night. If I already have decreased muscle strength, can I gain this back if I start exercising more?
The easy answer is yes. You can improve your strength with exercise. It's probably worth speaking to a dietitian as well to see nutritionally if there's anything that can help optimize your strength gains there. If you are looking at doing targeted strength work, again, as I've kind of said throughout, it is worth checking or seeking advice from a physio or exercise specialist that can just guide you through what's safe in terms of strength or resistance training that you're looking to do.
Great, thank you. So that's all we have time for the questions today. But thank you everybody who submitted questions, and thank you Dr. Chara Kiraku and Sarah Jalali for answering those questions for us. That was really helpful and informative. So now we're getting near to the end of the webinar, but as always, I'm just going to highlight some resources from Myeloma UK that you might find helpful. So in particular, the publications that are on screen, the myeloma bone disease, you might find useful to have a little read off after this event today. Our pain and myeloma info guide as well provides more information and tips for managing pain as well, which might be useful. And we also mentioned the patient diary earlier, which can be helpful to keep track of any symptoms that you're experiencing and help communicate that to your medical team as well. And now just to talk a little bit about some of the other information and support services we have here at Myeloma UK. So myself and my colleagues Hayley and Ellen, we take calls on the Myeloma info line, and we're available Monday to Friday from 9 till 5. And we also answer any questions through the Ask the Nurse email service, so feel free to email us if you would like any further information. As well as the info packs and the info sheets that were being mentioned in the chat tonight as well. We have a range of publications, like I just mentioned, and you can download them from the website, or you can also order hard copies from the website as well, or you can phone the info line and we can arrange to get hard copies sent out to you as well. All of our previous digital info day sessions are up on our website and on our YouTube channel, so you can watch them when you like. And please do keep an eye on our social media and our website for announcements of any upcoming events. We also have a discussion forum, which allows you to talk with other patients or family members as well. And we have a range of support groups all over the UK, and you can find out more information about them on our website as well. So we've come to the end of our event today. Thank you to both Chara and Sarah for speaking this evening. And thank you to everybody who has joined us and for asking questions. We hope you found it helpful and informative. If we didn't manage to answer your question today, you can get in touch with us via the info line or via the Ask the Nurse service, or you can ask your own medical team as well. And it's with thanks to our supporters that Myeloma UK can continue to provide free digital events just like this one for patients and their families. So if you would like to support the work of Myeloma UK, then please visit www.myeloma.org.uk/donate. You can now rewatch this webinar on our Facebook page, and it will also be available on our website soon as well. So once again, thank you for joining us, and I hope you all enjoy the rest of your evening.
Thank you.
Thank you.